Hello everybody. Today we are going to operate a case of simple right ovarian cyst. This is case of primary infertility, and you can see there is a big cyst on right side of the ovary, and you can also see that ball is not prepared at all. Now I am able to see that all the ovary is involved. I want to see there is any other healthy ovarian tissue behind of the cyst or not. And my plan is to remove the cyst en toto. I want to enucleate the cyst first, and then I will remove or I will aspirate that. The fallopian tube. And in ovarian fossa, intestine is going. I have to remove that intestine so that I can identify any ovarian tissue there. Yes, now we can see that there is no other ovarian tissue behind of this cyst, and in this cyst the complete ovary is involved. So I will try to make a good plane in between the cyst and the ovarian tissue. I am using all the atraumatic instrument so that there is no possibility of puncture of the cyst. Even after giving the head low, intestine is coming in between, and I am starting from the most loose connection of this cyst with ovarian tissue. Most likely I will be able to create the plane in between the cyst and the tissue. Once I will create the plane, then there will be the very easy to me to enucleate the cyst. Hopefully this is a good plane. Bleeding is controlled. Now I will extend this incision, and meanwhile I have to protect the fallopian tube also, because in future this patient is going for natural pregnancy. Yes, this is the ovarian tissue and this is the fallopian tube. I am far from fallopian tube. I am also trying to protect the some ovarian tissue. Still I am unable to find the good plane, but hopefully I will find the good plane. Yes, this is the right plane. And once I will reach in right plane, after that there will be no bleeding at all. I'm trying to avoid the puncture of the cyst, because if I will puncture the cyst, then there is too much difficult to separate the cyst wall from the healthy ovary tissue. It will create a lot of problem. So my main motto is to enucleate the cyst completely, then I will aspirate. Now you can see right now I am in a good plane and there is no bleeding at all. Now just I have to separate the cyst wall from the healthy ovary. There is very less healthy ovary. In right side you can see there is a whitish margin. I will try to protect it. After reaching in right plane, there is no difficulty at all. I have to just separate and then I have to cut. When I am cutting that same time I am lifting my instruments so that energy cannot be spreaded to the ovarian cyst. And if I will touch my bipolar to the ovarian cyst, then there is possibility of rupture of the cyst that I don't want. Now more than 50% job is done. Now just I have to separate few fibers. Little bleeding. Control just one or two burst is there. Now I just have to use traction and counter traction that will separate the cyst. You can see how easily it's getting separated. Yes, I'm able to separate now. My assistant is trying to hold one side. Now I'll cut this part also. I think this is the best way to operate simple ovarian cyst. And the most important in that kind of cyst is just to find out the good plane. Once if you reach in the good plane, then after that there is no difficulty at all. And this is the healthy ovary tissue that I have to protect it. Now for separation of this I have to show a lot of patience. Now I'm peeling off. Yes, now I'm able to separate it. Good one. Few more fibers is there. I'm using all the atraumatic instrument, that's why I'm not able to hold the cyst wall. But if I will use the tooths or any other instruments, then there is high possibility to get rupture of the cyst. That's why I'm not using that. Now I will separate it slowly and slowly and right plane. Remove this fiber. Go on. Almost it gets separated. I think 10 to 20% is remaining, that I have to separate slowly. Now I don't want to get it rupture. You can see the cyst is coming like the cricket ball. You can see now we are near to separate fully, and the time starts as is just 12 minutes. Now in my mind only one thing is going on, that I don't have to rupture it. That is the only intention right now. After rupture of the cyst, there is too hard to separate the cyst wall because that is very fragile. Okay. I think almost the job is done. It will be separated by the gravity. Most of the time cysts get rupture at the base, so somehow we have to manage that it should not get rupture. Till now there is very less bleeding. Intestine is giving me trouble. Little losing is there. I have to control. These are the feeding vessels. Few more fibers. For this kind of dissection need a lot of patience. This is the complete and edited surgery. This is the base, little difficult. Now we don't want to get it rupture. Yes, now it's separated. You can see there is healthy ovarian tissue. Whitish ovarian tissue is still present. That in starting I told that I'll try to protect it, to preserve it. That is preserved. This is the last fiber. And cyst is separated completely without rupture. For a big achievement for me. You can see behind of this is there is healthy ovarian tissue is there, whitish tissue, this one. Okay, now we'll aspirate in last this cyst. Completely intact, there is no rupture at all, even minimum rupture is not there, like a small football. This is the surgery site. I'll check for any active bleeder if it's there, and you can see that the tube I didn't touch in my surgery, looking like unhealthy at all. This tube is not healthy. Pure ovarian tissue is remaining and no active bleeding is there. You can also see there is no active bleeding. So previously my plan was to suture it, but right now it's not required to suture it, so I left. Okay, this is the one side. Now coming to different another side. This is the left ovary looking healthy. and we'll check the tube as well. After that we'll do CPT also, chromoperturbation test. Now my vaginal attendant will push the dye and we'll see the free spill or there is not. Left side of tube we are doing CPT now. Pushing, yes, you can see dye is coming, so left tube is patent. Now coming to the right side, this tube is looking unhealthy. Don't think so it will be open. Okay, you can see there is a distance. Now my assistant is pushing the dye and there is no filling at all. We'll see the femoral end. Yes, this is the femoral end. Now pushing again. Dye is not coming at all, so this side of tube is blocked. One side is open and right side is blocked. Okay, now now coming back to the cyst. Now we'll aspirate this because this is a clear cyst, so there is no harm if minimal spill is there. All the tumor markers is negative and this is a clear cyst only. So first I will puncture and then I will suck it out. Yes, it's puncture. Now I will suck it out. You can see clear fluid is there inside the cyst. And the beauty of the surgery that it's removed completely encapsulated, so there will be very less chances of recurrence. Now I'll remove the cyst wall through 5 mm port if I will be able to remove. Otherwise then I have to change the camera and then I will remove by 10 mm camera port. Okay, I hold from one side and now I am removing it with port. Okay, now it's come outside and my assistant is pushing from inside the peritoneal cavity and cyst is gone outside. We did all the surgery by all the 5 mm ports except one camera port that is 10 mm. Now we can see there is no bleeding at all. Still you can see the color of the water, it's clear. Minimal oozing, 1-2 capillary might be there, not a problem. For same kind of surgery, it's very simple surgical step, you can subscribe my channel. Thank you.